Hi, everybody. My name is Amy Sunning. I'm the Adult Services Manager here at Mentor Public Library. Thank you for joining us this afternoon to meet Dr. Zellers and hear his talk on COVID-19 and the heart. He's a cardiologist with Lake Health Physician Group. Dr. Zellers, you can take it away.
Okay, thanks for joining us. Can you guys hear me okay? Amy, can you hear me?
I can hear you.
Okay. So today we'll be talking about COVID-19 and the heart. Going to be trying to answer some questions. There's a lot of data out there. Some of it's more credible than others, and I think the objective today is to just update you all on what's known and what's not known. The overview slide is the only one that didn't translate over during our issues with the computer, but essentially we'll be looking at a general overview of COVID-19, course of illness, the latency period, some constitutional symptoms that occur early on, followed by the more severe symptoms that can occur, and then the long-term sequelae or effects and our COVID-19 long haulers that they've been termed. We'll go over some statistics as they stand out, and then we'll get into some questions, some commonly asked questions. If I have heart disease, am I at higher risk for getting sick from coronavirus? Can COVID cause me to have a heart attack? Can COVID cause heart failure? We'll go over viral injury directly, as well as heart failure that occurs with the systemic illness from COVID. And another question, COVID, can it cause me to have a stroke? We'll go over that. We'll go over arrhythmias in COVID-19. Should I be taking my ACE inhibitor? That's your lisinoprils, quinaprils, captoprils, all the prils, if I get COVID. And then, is it safe to resume exercise after I've recovered from COVID-19? And then, is it safe to go to the hospital? We'll go into some of the statistics there. So we'll start with COVID-19, course of illness and overview. So generally, there's a latency period. It can be anywhere from 2 to 14 days. This is the time period where a patient may be infected with the virus before showing any symptoms. And the accuracy of testing at this point is extremely variable. People can be infectious on average 48 to 72 hours prior to experiencing symptoms, and as many as 33% of patients remain completely asymptomatic through the course. As far as the symptoms, the early COVID-19 symptoms, those can occur for up to 4 weeks. And as you can see, depending on what source you're looking at, the incidence of these symptoms is extremely variable. Fatigue can be anywhere from 15 to 90%. Shortness of breath or dyspnea, 10 to 70%. Chest pain or tightness in 12 to 44%. And this is where it tends to overlap with some of our known cardiac conditions and makes things a little confusing. Cough and anosmia or loss of smell can occur in up to 50% of people. You have your ongoing symptoms. These are symptoms 4 to 12 weeks out following the acute illness, and then even further 12 weeks beyond, 12 weeks after the onset. And these are symptoms that aren't explained by other alternative diagnoses. These are the long haulers, so to speak. So this is a report from Chinese Center for Disease Control. Mild disease is reported in 81% of people, severe disease in about 14%. 5% are critically ill, and overall mortality for them is about 2.3%. And for us, at this point, is 1.8% in the US. Risk factors for severe illness would be increasing age, cardiovascular disease, diabetes, hypertension, malignancies, particularly blood-borne malignancies, lung and metastatic or advanced malignancy, kidney disease, obesity, and smoking. And this is just another demonstration of the timeline. Days 1 to 7 are the flu-like illness, the constitutional symptoms, muscle aches, fever, cough. Anywhere in days 5 to 10, folks can experience more severe symptoms, and it's thought that a lot of it is from something called the cytokine storm, which is essentially just a ramped up, revved up immune system where it's in overdrive. And inflammation and clotting, they are tightly related. And so when you have an immune system that's in overdrive, you have the propensity to form clots. So that's what we'll kind of go into and explain that a little bit better. ARDS is acute respiratory distress syndrome, kind of ties in with this hyperactive immune system. And if that's present, mortality or risk of death approaches 50%. So cytokines, so these are proteins that are present at varying levels in the bloodstream. They mediate growth, they're normal, they mediate growth, they mediate inflammation and immune response, amongst other things. When they're elevated and over elevated, sometimes they can cause damage to the our own tissues, lungs, heart, organ systems. They are elevated or are often elevated to some degree in patients with COVID-19 who are severely ill. And it's thought to represent this ramped up or dysregulation of the body's immune system. It is associated with poor prognosis or poor outcome. And certain cytokines actually become therapeutic targets, which is tricky because, as I mentioned, they are necessary for combating and ridding the body of infectious agents. So that, to completely suppress them wouldn't do any good. Steroids are routinely used in hospitalized and severely ill patients with coronavirus. And there are studies ongoing looking at other cytokines and targeting specific ones. But there's nothing, the data right now is conflicting. There's nothing definitive. So this is kind of a depiction of the cytokine storm and everything that can happen, the organs that can be affected, the systems in the body that can be affected. This is a figure from the New England Journal of Medicine, rather recent. You can see with the arrows, coagulopathy being the propensity of one to form clots. And you have damage to vascular structures. And then looking at the heart, low blood pressure, high heart rate, and cardiomyopathy, which is damage to the heart muscle itself, can happen directly from the virus or as a result of the inflammatory response. So long haulers, there really isn't a unifying definition. This is from a blog from the Harvard Medical School proposing a definition, which is a medical diagnosis of COVID based on both symptoms and diagnostic testing, not returning back to baseline after 6 months and having symptoms that suggest long COVID, but no evidence of permanent damage to the lungs, heart, and kidneys. And we're seeing this. I've seen it several times in my office. Patients who were infected with the coronavirus as early as November, still having symptoms, and all the tests are coming back normal or inconclusive. So this is a real thing. These are the long hauler symptoms. Again, similar symptoms here: fatigue, dyspnea, chest discomfort, cough, loss of smell, lasting 2 to 3 months, sometimes longer. The less common symptoms, and then you have your psychologic symptoms, the post-traumatic stress, PTSD from the disease itself can last 3 months or longer as well. Reduction of quality of life, also an issue. So here's our statistics currently, or at least as of March 30th, 30 million cases, 547,000 deaths. So we're right at about 2%. So I try to keep these, although they do tend to get a little busy, but this is, if I have heart disease, am I at more risk of getting sick? So just if you pay attention to the disease states listed in bold: hypertension, diabetes, and cerebrovascular disease. These are all studies looking at patients with COVID, symptomatic COVID-19. And this is the prevalence of comorbid conditions or other conditions such as high blood pressure, diabetes, or cardiovascular disease. So you can see that there is a significant risk if one has either of these three. These tend to be the big three. This was a study from China. This is a study from the Lombardy region in Italy, which was the kind of the second area to get hit pretty hard with the virus, looking at patients with and without hypertension that are hospitalized. As you can see, with hypertension, more of them either still in the ICU or died in the ICU, and without, more were discharged, more favorable outcomes there. So this is a study from New York City looking at the comorbid conditions or other medical problems that the patients, hospitalized patients had, and whether or not they were requiring mechanical ventilation, which is the breathing machine. And as you can see, diabetes, hypertension, and coronary disease, those folks were at more risk for having severe illness and requiring the breathing machine. So can COVID cause a heart attack? That's a loaded question. I'll try to kind of break this down a little bit. So we'll start with what is a heart attack. So heart muscles, they require oxygen and nutrients and blood to be delivered to the heart muscle, just like anything else. And that's done through the coronary arteries. There are two different kinds of heart attacks, more or less. The first one is when blood flow is perturbed most commonly by plaque. That's your type 1. That's the obstruction in the artery that leads to a halt of blood flow to the heart muscle. Then there's a second type of heart attack, which is less commonly known to the public, but probably more commonly dealt with in the hospital. And that's when the demand of the oxygen and nutrient demand of the heart as it's enduring stress exceeds the amount of supply. And we call that a type 2 heart attack or myocardial infarction. And the way we diagnose these is looking at the patient's symptoms and EKG and blood test. There's no one element that's used to diagnose. It's all of these three components together to make a decision. Our experience suggests that COVID-19 can present itself this way or mimic either one of these scenarios. Myocardial injury in the setting of COVID-19, regardless of the cause, is associated with worse outcomes. So, as mentioned, a blood test that we use quite often in the hospital, cardiac troponin, this is a blood test that indicates that there has been some heart muscle injury. Doesn't really tell us the cause. That's what's kind of left up to the clinician to discover. But when that's elevated, when this blood test that suggests heart injury is elevated in the bloodstream during COVID-19, there is a higher risk of lung injury, which is the ARDS, death, mechanical ventilation, and arrhythmia. And so the blue being the patients with the positive test and the red being the negative. So the type 1 heart attack that I had mentioned prior, there are different suggested mechanisms that COVID-19 can be influential. It affects the body systemically, causes systemic inflammation. And as I had mentioned, wherever there's inflammation, it's closely tied to coagulability, which is the tendency for the body to form clots. That happens on a systemic level. It also happens as a directly into the plaque. So the intracellular pathogen, COVID-19 is an intracellular pathogen, and it can invade the plaque and cause a local inflammatory response, or so we think. This can lead to plaque rupture, and this can lead to an occlusion of the artery around the heart. So the type 2 myocardial infarction or the type 2 heart attack, that's supply-demand mismatch. So with a systemic infection, you have an increased demand, the heart rate increases, you have a fever, and then you also, in this particular circumstance, have a decreased oxygen supply, particularly if the lungs are affected by the virus. So that's the type 2 injury that can happen with coronavirus. This is from Journal of American College of Cardiology. This is putting together a bunch of studies that looked at troponin levels in COVID-19 patients. And as you can see, there is a prevalence. Quite a few patients did have elevated troponin levels. more so in the patients that were severely ill. Just going back to, you have evidence of heart injury, outcome is a little bit less favorable. So the myocardial infarction, the heart attack caused by blockage, that's inflammatory mediated plaque rupture. So this type 1 infarction, it sounds scary, coronavirus invading the plaque and causing problems, but really in our experience, this happens probably, it's not reported, but it happens a lot less frequently than the second, the supply demand mismatch that occurs from a systemic illness. I will show one study that does look at the type 1 or the artery occlusion. There was a single center in the US that looked at 115 consecutive patients presenting with a heart attack, the occluded artery, and they looked at the patients and broke them down in terms of who had coronavirus and who didn't. This was in an area where the prevalence of coronavirus was quite high amidst the pandemic, and looked at baseline characteristics. So even with the coronavirus in play, the patients with the occluded artery were more likely to have hypertension, or high cholesterol, high blood pressure, diabetes, and a smoking history. So that definitely comes into play. But with the coronavirus, we did see, or this center did see, that there was a lot more clot involved with the occlusion of the artery. And this goes back to the whole mechanism of increased inflammation and increased clot formation. So the COVID-19 patients had a lot more issues. So if they had prior stents placed, there were a lot more issues with clot developed on the stent, more issues where more than one artery was involved in clot with clot, and then more complex and just more bulky clot seen in the COVID-19 patients. How about now? Any questions now? Are we still doing okay?
There is one question now. The question is, has COVID been linked to new onsets of arrhythmias?
Yeah, there has been some association, but it's multifactorial. We'll get into that. I have a whole section on that, but yes, for various reasons. Some of it has to do with the disease process itself. Some of it has to do with the body's response to the disease, and some of it actually has to do with the medical therapy that we use for the disease that we've discovered. So there's a whole section, and I'll get to that for sure.
Okay, one other question was, does COVID affect ejection fractures and cardiomyopathy?
Yes, it can do that. I think we're kind of getting into that in our next section here.
Okay, thanks.
So that's actually a good segue into this. So can COVID cause heart failure? So heart failure, what's that? We'll start with a simple definition. So it's the heart muscle is a pump that's responsible for pumping oxygen and nutrients to every organ in the body, including itself. Heart failure is simply when the heart can't keep up. The demand of the body exceeds what the heart is able to supply. Reasons for decrease in supply, well, we talked about heart attack or myocardial infarction. This can cause heart muscle cell damage or death that requires a weaker pump. So in some respects, I think this is part of the answer to that question is, a damage to the heart muscle caused by the virus, either directly or indirectly, can affect the ejection fraction, which is essentially how much blood leaves the heart with each beat. It's not normal for 100% to leave. In fact, with each heartbeat, about 50%, or maybe a little bit less than 50% hangs behind. A little bit more than 50% gets ejected from the heart. So when the heart muscle is injured, that can change. So yeah, the answer is yes, it can affect. There's also direct viral injury to the heart muscle, which is rare. We'll get into that. That was a big to-do for a while and pretty much almost canceled pro and college sports at one point, but we'll get into that in a second. And then lack of oxygen from the lungs as a result of the pneumonia or pneumonitis that COVID causes. This can affect oxygen supply. Increased demand, we went over that a little bit, hypermetabolic state and the infectious state that COVID causes, the systemic illness. This just kind of puts it all together. This is on the left, we have a little figure of the coronavirus and the ACE2 receptor, which is the receptor that it adheres to and makes its way into the cells of our body, our lungs, our heart, etc. The illustration on the right looks at just all the effects that the virus can have on our system. Hypoxia being low oxygen levels that is caused by the pneumonia from coronavirus. There could be direct viral entry and toxicity to the heart muscle itself. Again, which I said, we're starting to learn that it's pretty rare. And then actually vasculitis or endothelial injury of the blood vessels around the heart that can occur too. So that's the heart failure piece. Can COVID cause a stroke? We'll start with, well, I see there's some questions. You want me to, I guess we can stop here and answer these questions.
Okay, I had somebody typed in asking about if I get COVID, should I continue to take my daily medications like Lasix, aspirin, blood thinners?
Yeah, so that's a loaded question. I think the short, easy answer for you is I would talk to your physician, your prescribing physician about that. I think there are some circumstances, for example, where the water pill or the Lasix would need to be adjusted based on the demands of the body and how hard the heart needs to work to get over the infection. So if it's not that the medications are stopped or changed, they probably need to be monitored a little bit closer. So I think the best thing to do in that circumstance is to present that question to your physician, whether it's your primary care or cardiologist or both. So.
Okay, that's all I have unless anybody else wants to ask one.
Okay, so can COVID cause a stroke? So it makes sense that there would be an increased incidence of stroke. Much like the heart attack affects the heart, stroke is a disruption in blood supply to the brain. So very similar in mechanism, just different organ. And one of the most common, there are two types of stroke, more or less, and the most common by far is the ischemic stroke, and that's the disruption of the blood supply due to an obstruction, plaque, and or thrombus, most commonly, thrombus being clot. Then there's the hemorrhagic stroke, which is far less common, and that's bleeding from a ruptured blood vessel. COVID infection causes inflammation, which can cause plaque in the arteries of the brain to become unstable or rupture. It's also thought to make one prothrombotic or more capable of forming clots. So the logic and the mechanism is there. However, and thankfully, this is just another, just kind of highlighting the areas where the pertinent areas as it regards to stroke. But moving on, this Italian study looked at 725 hospitalized patients with COVID, and 119 or 16% had neurologic symptoms, and only 31% of those 16% had an ischemic stroke. So what's that, 4 or 5%? Of these patients actually had a stroke, and 6% of them had a bleeding stroke. Here's a study from New York looking at the surge of coronavirus, and then you have stroke, transient ischemic attack, or mini stroke, and MI on the same graph. And you can see that there really isn't a change. There isn't that uptick that we would expected to see because of that mechanism that's there. So this looked at 24,000 hospital discharges, 10% of them diagnosed with COVID, 566 or 0.2% presented with a stroke. So patients diagnosed with COVID actually were at 1/4 the odds of having a stroke than the non-COVID patients. So I don't know that we can say that COVID is protective from stroke by any means, but I think at least we can say that we're not seeing that propensity or increased likelihood of having a stroke in COVID patients. Now, those that did present, those COVID patients that did present with stroke, they ended up not doing as well as those that didn't have COVID. I don't think that's to anyone's surprise. So this was interesting because this is a patient population that we don't typically see strokes in. It's strokes in young patients, strokes involving large vessels or multiple vessels seen in young patients. So there's a 7-fold increase of stroke with COVID compared to the flu in younger patients. I think it's, like I said, shocking and draws attention because of the increase in absolute number. I mean, the percentage is still small when it comes to all of the COVID patients and how many are affected by this, but just seeing it in this age group, I think is catching some attention. So the mean age for large vessel stroke is 53 in COVID patients and 74 in non-COVID patients. This is the can COVID cause arrhythmia? And the heart has plumbing and it has electricity. Each heart muscle cell is capable of conducting an electrical current, and that current tells the heart when to pump, how fast to pump, and how strong to pump. Usually the impulse starts at the SA node or sinoatrial node and works its way down from the top 2 chambers to the bottom 2 chambers. Arrhythmias are just simply impulses that begin elsewhere and or that travel differently throughout the heart muscle. This can compromise pump efficiency to some degree. So this was a paper from Wuhan looking at patients infected with the coronavirus. 16.7% of these patients did develop an arrhythmia during their hospital stay. 44% of those in the ICU developed an arrhythmia. They didn't really specify, and we'll get into these in a little bit more detail, but definitely a propensity to cause arrhythmia in those that are sick. This is also another paper looking at fatal outcomes out of China, and it looked at 187 patients, and 5.9% of patients died from ventricular fibrillation, which is can be a fatal arrhythmia. One thing I do want to point out, and even with the other study, all of these are consistent with findings in patients with the flu. So it's no more or less likely to cause an arrhythmia than, let's say, the flu. Just an overall summary of how it can cause arrhythmias. Like I said, direct viral effect of the heart muscle itself, which can cause myocarditis, which is inflammation of the heart muscle. The systemic illness that COVID causes, affecting the lungs, causing respiratory failure, lack of oxygen. This is all pro-arrhythmic or can cause arrhythmias. And then there's the drug-drug interactions, whether it be the drugs that we use to treat coronavirus or the drugs interacting with medications that patients are already on to begin with. Different arrhythmias from COVID-19, SVT, which is an arrhythmia, supraventricular, which just starts in the top 2 chambers. Atrial fibrillation and flutter are also arrhythmias that start in the top 2 chambers. Complete heart block is where the top 2 chambers don't speak to the bottom 2. And then you have your cardiac arrest, which is when the heart stops. And then your ventricular tachycardias, which are your more serious, more life-threatening arrhythmias. We have your mechanisms that we discussed already and management strategies. There really isn't much in terms of specialized management other than just acknowledging and understanding the different medications that can cause or can put one at risk for arrhythmias. So I put this up not to focus much on the content, but just the different medications that are listed here. These are medicines that have all been in the press with regards to coronavirus and possible therapies. As you can see, most of them do have some risk of causing arrhythmia, and we'll go into a couple of the more popular ones. So this is hydroxychloroquine and azithromycin. So this was a big to-do because it was kind of the first drug that had showed some promise in treating or at least making coronavirus symptoms less dramatic and less fatal. There was a study that came out of France. It was a small study. It looked at about, I think, 30 patients, and patients receiving hydroxychloroquine, which is a drug that was previously studied in HIV patients. And it was found actually to stop replication of coronavirus 19 in vitro, which means outside of the body. This is, test tube science, essentially. And then we took azithromycin, which is an antibiotic very commonly used. That's your Z-Pak. And that's also has anti-inflammatory properties. And these drugs in combination were used in this group of patients. Well, it's a small study. It wasn't randomized, and they actually selected, they took the patients that did poorly and did not use them in the final analysis. It just blows my mind how this could have made the press. But I think at that point we were kind of grasping at straws. So anyway, it's used, and it has been used, but in clinical practice, we've found that it does increase, especially in combination, and when you use the hydroxychloroquine in high dose, it alters the conduction system, and it makes kind of creates an environment that is pro-arrhythmogenic, and it can cause these ventricular arrhythmias. So we don't use it quite as much anymore. All right, so should I keep taking my ACE inhibitors? Those are your lisinopril, captoprils, all the prils, and you can even include the ARBs, which is the losartans, the valsartans, the sartans. So coronavirus enters the cell via the ACE2 receptor, which is present on several types of heart cells, several types of cells, heart, lungs, etc. So there's conflicting data that exists on the influence of ACE inhibitors on ACE2 activity, so that receptor activity in various tissues, and how that affects the susceptibility to COVID-19. What it boils down to is there's just not sufficient data, and where there is, it's conflicting, that exists to recommend stopping the ACE inhibitors or the ARBs, which are otherwise life-saving for other medical issues, such as high blood pressure or heart failure. Several societies recommend continuing these medicines, and there are randomized controlled trials that are ongoing. So hopefully that answers part of that other question there. So activity after coronavirus, is it safe to exercise? So that goes back to the comment about canceling sports, which was devastating on a personal level for me. But there's a German study that came out right at the height of the first peak. It was 100 COVID-19 positive patients, and they looked at cardiac MRI, which is a good test to look for heart muscle inflammation. And they found that 78% of these patients had some effect to the heart muscle as a result of the virus. And 60% of them had findings concerning for ongoing inflammation. Since then, so that's alarming, and I think that caught wind, and there was a lot of concern for resuming activity, especially in pro athletes. The problem is there was no control group, and a lot of these findings that we have found can be normal findings in athletes in particular. Since then, and actually pretty recently, the 2 US studies using the control groups for comparison that suggest that the incidence of direct viral damage to the heart muscle is way, way less than we thought it was, about 1 to 3%. So these are not your long haulers. These are patients that do have identified effects, physical effects on the heart muscle. And the percentage is a lot less than we initially thought. So my answer to that is yes, it is safe to return to exercise. Now, if you're still having symptoms, it's definitely worthwhile getting evaluated. And I do see a fair amount of patients, like I said, that are still symptomatic from their infection in the winter, sometimes even back to Thanksgiving. And I'll start with an evaluation, maybe just a basic EKG and an echo, and we'll go from there. And if those are normal, then I'm pretty happy. Sometimes, though, we do send folks for cardiac MRI. This is something that the Journal of American Cardiology put together, just a recommended algorithm in terms of how to evaluate these patients that are still having symptoms. This is for athletes, but I think it applies to anyone. They are using, or the So EKG, yes. Echo, yes. Clinical evaluation by a cardiologist, yes. They also have that blood test that looks for heart damage. I tend to disagree with that. I think that's more of a, and that's another talk in and of itself. But that's more of an inpatient tool, very little use in the outpatient setting. Referring to that blood test that looks for heart damage, or troponin, as it's called. Okay, so the big question, is it safe to go to the hospital right now? And we're going to take, before we answer that, we're going to take a little look at cardiovascular disease and what's been going on with it during the pandemic. It remains extremely prevalent in the US. It hasn't gone away just because the virus is here. It still remains the #1 cause of death in the United States. And what we have seen is that not only diagnostic testing, but the admissions for heart failure and heart attacks has declined tremendously. So diagnostic testing, that's your cardiac cath, that's your echo, that's your cardiac MRI, stress test. This study looked at 909 inpatient and outpatient centers, 108 participating countries, and they looked at 3 months. They looked at March 2019, they looked at March 2020, and they looked at April 2020. And they found when they compared March to March, there was a 40% reduction in cardiac testing worldwide, 42%. When they looked at March to April, 64%. So well over half cardiac testing going on in the spring of 2020. I should say well less than half in the spring of 2020 versus the spring of 2019. Reduction in ST segment elevation, cardiac catheterization, lab activations. So this is your emergent cardiac catheterization that occurs for an artery that becomes occluded abruptly. This is 9 high volume cardiac centers in the US. They looked at monthly cath lab activations. You can see there's a precipitous decline. And I'm telling you, it's not because the disease process isn't there. It's, and a lot of it has to do with just not wanting to come in for fear of the coronavirus. This was a study from Italy looking at 4 provinces where coronavirus was extremely prevalent. We saw a 58% increase of out-of-hospital cardiac arrests, people not coming in for fear of the virus and suffering cardiac arrest at home. Same thing here, this was in New York, increase in cardiac arrest. So what are the hospitals doing? This kind of ties into, is it safe to come into the hospital? One thing that I think worldwide we've done a very, very good job at is really streamlining the process of opening an artery that becomes 100% blocked all of a sudden. So that's your, I'm having chest pain, I'm calling 911, the discovery of a blocked artery, the opening of a blocked artery. We're very quick at that, in doing that. What we've done, or what these societies have done, is they've incorporated a couple of extra steps into this process that make the process safer for not only the patient, but the providers. And so this is kind of a proposed algorithm or an adaptation of our previous algorithm, just inserting a couple extra steps to ensure safety when it comes to the coronavirus. And we pretty much do this here at Lake, and I think we've done it pretty well throughout the pandemic. So despite the pandemic, I would not ignore your symptoms. Some of these symptoms that can be coronavirus can also be heart disease. And you know, I think presenting to the hospital sooner rather than later still is the best thing to do. I see too many circumstances where patients will present to the hospital weeks late, where they should have presented earlier, and the outcomes are just not as good. So if you're having chest pain, particularly if you have a history of heart disease, the response is still the same. Call 911, get yourself into the, well, not yourself, call 911 and get into the hospital. this is just a little bit more of the same. This is something that Lake Health had put out. In addition to getting yourself to the hospital, learn the early signs and symptoms, discover your accredited chest pain centers. Chest pain center accreditation is a process, and that's something that Lake has been a part of since 2009. We've been accredited. And then just overall safety precautions, some of the things we've done or hospital systems have done: mandatory mask and protective eyewear at all times in patient contact areas, temperature screening. At one point we were having, there was no visitation, and now it's limited. We have COVID-19 designated units, and a lot of the procedures that we do, at least from a cardiac standpoint, we're implementing same-day discharge if we can do it safely, just to minimize exposure. So you come into the second floor, everything's done on the second floor. We watch you for a couple hours, and then you go home. You're pretty much almost never in the hospital. Yeah, so these are some things that we've done. And that's pretty much all I have for you.
Great, thank you. Anybody else have any further questions for the doctor? I did get a couple questions. Somebody emailed to me that wasn't sure if they could make it or not about wearing masks, and they wanted to know, was it safe to exercise with a mask at the gym?
Yeah, I have mixed feelings about that. I don't think we're going to know for sure the effects of these masks for some time. What I do think has been proven is that it helps in terms of reducing the transmission of this virus, but in terms of the effects it has on the lungs, the heart, everything long term, I mean, we're not going to know for many years. But at this point, it's the virus we're dealing with, and it's the virus that's the issue, and it'll continue to be as long as we don't, distance ourselves and wear masks when appropriate. As far as exercising in it, I guess my recommendation would be to find something you can do for exercise where you don't have to wear a mask. I mean, I've tried to exercise in one, and it's not easy.
Okay, that was a good question. Another one was, if I am at a higher risk, should I double the mask, do a double mask, and does that affect my oxygen levels?
So I don't think the mask affects oxygen levels to a significant degree. The double mask thing, I'd be honest, I'm not. I heard that recently that's being recommended. I haven't seen the literature to back that up, so I don't know if I can answer that.
Okay.
Or wearing single masks in the hospital, if that helps.
Okay. I don't see any new questions in the chat. I'll just ask one more time because I did get another question about the vaccine. Is the vaccine safe for heart patients? And when I get the vaccine, should I go ahead and take all my medications that day on vaccination day?
Yeah, I don't think that vaccination day, I don't think shouldn't change your medication regimen. I think it's absolutely important and safe. I recommend the vaccine to all of my patients,
Okay.
just for the reasons that we highlighted with folks that have heart disease, high blood pressure, diabetes. Not only are you more at risk for the virus, more at risk for getting sick, from the virus itself.
Is there any vaccine that you recommend more for a heart patient? It says, I've heard to get whatever vaccine is available in my community, but as the supplies get better and better, is there one that is actually better for heart patients? Like
I don't think
Moderna
so.
or
I
Pfizer?
think it's whichever one you can get. I
Okay.
do the Johnson & Johnson, that's the one dose. I think if we're to split hairs, I think it's a little bit less effective. We're talking, both of them are 80s to 90% effect. I mean, I don't think it's statistically significant. So no, I think all the vaccines are whichever one you can get your hands on.
Doctor, thank you so much for your time. I appreciate it.
Sure, anytime.
All right. See you.